Hello, my name is Osama. Naga will start a new section, Immunologic Disorders. Check the third edition for all updated information. My objectives in this presentation to be able to differentiate between the most common and high-yield immunologic disorders and when testing for immunologic disorders should be considered. First of all, we need to know that primary immune deficiency disorders in children are very rare. Normally, a child may have 5 to 6 upper respiratory tract infections per year, and this is common. Unlike a child may have 11 to 12 upper respiratory tract infections per year, and this is less common. URI is commonly associated with otitis media in 30 to 50% of the cases. Unfortunately, URI is commonly treated with antibiotics with no need, and if you leave them alone with only supportive care, these children, they will recover with no problem, with no need of antibiotics. So what to tell the parents when you have these cases? Reassurance. This is normal, this is healthy. No workup for immunologic disorders is indicated. So this is very important to know. I will give you a few examples of red flags for primary immune deficiency disorders. If you have a child with recurrent infection and there is a positive family history of primary immune deficiency or early death because of overwhelming sepsis, you should consider primary immune deficiency disorders. Failure to thrive, the child is not growing. Increasing frequency of the infection as the child is getting older. This is unusual. Normally, the children, as they grow, they have less recurrence of infections. And if the child is growing more and having more serious infections, recurrent hospitalization, you should consider primary immune deficiency disorders. Recurrent serious infections like recurrent meningitis, recurrent osteomyelitis in different places, this is abnormal, this is unusual. If you have a child with more than 8 episodes per year of acute otitis media, especially if it's complicated by 1 or 2 episodes of acute mastoiditis, this is a red flag. Pneumonia more than 1 episode per year is a red flag. Enteric infections, for example, Giardia, Cryptosporidium. Unusual sites of infection, for example, abscess in the liver is a red flag. Abscess in the brain, osteomyelitis in different locations, this is unusual, this is a red flag. Opportunistic infections, for example, Aspergillus or nocardia. Persistent thrush in a child more than 1 year of age is unusual. T cells is produced by the bone marrow. T cells travel to the thymus gland for maturation. Thymus gland is located in the chest and appears very easily in a chest x-ray of a newborn as a large shadow around the heart or a cell sign. This is healthy to see in a newborn. And the T cells will differentiate in the thymocyte to helper cells, cytotoxic cells, memory cells, natural killer cells, suppressor cells. I will focus here on the helper and cytotoxic. The helper cells will known as CD4 positive T cells, and these cells will stimulate the maturation of B cells to plasma cells to produce antibodies. This process of maturation occurs where? In lymph node. For example, tonsils. So it's very healthy to see a prominent tonsil in a child. So prominent tonsils in a child is a healthy phenomenon. You don't want to recommend the removal of tonsil because just they are large, except if they are causing obstructive sleep apnea, for example, pulmonary hypertension, dysphagia. But generally, large tonsils are healthy. Reassure the parents. This is part of the immune system. If a child is having a problem with the B cells like primary immune deficiency or humoral deficiency, they will not have tonsils, and this is actually unhealthy. This is unusual. And the plasma cells produces antibodies, for example, IgA, and this appears in the mucosa and the GI tract. And IgE, very important to fight against parasites and very important for allergies. And the IgG and IgM. IgM is a relatively large molecule, doesn't cross the placenta. The antibodies generally, like for example IgG, when they see bacteria, they coat the bacteria, they surround the bacteria, and they signal or they stimulate the phagocyte, like for example neutrophil or macrophages, to be attracted and bind to the antibodies through the FAC receptor to destroy this organism. On the other hand, you have cytotoxic cells. Cytotoxic cells will known as CD8 positive T cells. These cells will destroy the intracellular organism. For example, viruses or fungus or fungi and tumor cells. Also, it will play a role in the transplant rejection. This is just an overview of the immune system. General presentation of primary immune disorders: B cell defects. B cell defects or humoral deficiency or lack of antibodies, usually they present at 6 months of age or older, when the maternal antibodies disappeared from or cleared from the circulation of the infant. So the infants, they present with recurrent bacterial infection, especially encapsulated bacteria like Streptococcus pneumoniae or Haemophilus influenza, protozoal infection like Giardia, and enterovirus infection like recurrent ulcers or herpes angina because of lack of IgA antibodies. And the T cell defects, they present soon after birth with serious infections like viral infections, fungal infections, persistent thrush, mycobacteria, syphilis, or salmonella, PCP infection, or pneumocystis carinii. If a child is having T cell defects and B cell defects combined together, this is the most severe, and they will present with all different infections: virus, bacteria, protozoal, fungal, everything. Let's start with the high yield primary immune disorders. I will start with a severe combined immune deficiency disease, or SCID. SCID appears shortly after birth. It is because of absence of all immune function. Absence of T cell function and humoral function, so no T cells, no antibodies. The cause is genetic mutations. It can be X-linked, autosomal recessive. Autosomal recessive is because of adenosine deaminase deficiency, and this can be associated with buildup of toxic metabolites, and this will destroy the T cells, B cells, and natural killer cells. And the sporadic form. Clinical presentation of severe combined immune deficiency disease. From the name severe, so the clinical presentation is severe sepsis, shortly after birth or before 3 months of life, recurrent infections, pneumonia, failure to thrive, chronic diarrhea, dermatitis, or severe eczema. There is no B lymphocyte to differentiate in the tonsils or lymph nodes, so there is no tonsil, there is no lymph nodes or adenoid. There is no T cells to differentiate in the thymus, so the thymus is very small. This disease is a medical emergency. Severe combined immune deficiency requires early treatment with bone marrow transplant. If you do a CBC for these children, you will see severe lymphopenia from birth. If you measure the immunoglobulins, you will see the severe decrease or absent immunoglobulins. If you vaccinate them and measure the antibodies after vaccination, you will not see any antibodies. No antibodies for diphtheria, no antibodies for tetanus, no antibodies for pneumococcal vaccine. So remember, severe combined. Combined means no B cells, no T cells, severe infection with bacteria and protozoa, with virus and fungi. X-linked A-gamma-globulinemia. This disease affects the boys only. A-gamma-globulinemia means no antibodies. This disease is a defect in the B lymphocyte development, so the naive B cells cannot develop, cannot mature to be plasma cells, so there is no antibodies. Why? Because of mutation of a very important enzyme is well known as proton tyrosine kinase. This enzyme signals the naive B cells to mature to be plasma cells, to be antibodies. When there is a mutation here, means there is no antibodies. So this disease presents at 6 to 9 months when the maternal circulating antibodies disappear. So the infants, they present at 6 to 9 months. Clinical presentation of X-linked A-gamma-globulinemia, very easy to remember. Because of lack of PTK or mutation in PTK, the naive B cells cannot make any antibodies. So lack of immunoglobulin G or IgG will be associated with a recurrent infection with encapsulated bacteria. For example, Streptococcus pneumoniae, Haemophilus influenza, meningococcus, or staph. Lack of IgA, recurrent infection with enteroviruses, and also lack of IgE, recurrent infection with Giardia or chronic infection with Giardia. Lack of maturation will be no tonsils, no palpable lymph nodes. The lymph node is not working. There is no differentiation in the lymph nodes. Very important to avoid giving any live vaccines to these children. Do not give them MMR, varicella, or live influenza vaccine. The diagnosis flow cytometry will show no mature B cells in the flow cytometry, and if you do antibody level, there is no antibodies. If you do antibody function, like after giving vaccination, there is no antibodies after vaccination. The treatment is simple. These children, they do not have antibodies, so to give them ready-made antibodies, either IV or subcutaneous. Common variable immunoglobulin deficiency is because of lack of B lymphocytes or plasma cells. This disease will be associated with low level of most or all Ig or immunoglobulin classes. Genetics of this disease is sporadic, autosomal recessive, or autosomal dominant. The most important points to remember about this disease appears during adolescence, very rare to appear before 6 years of age. The level of immunoglobulins is variable. So some of them very low, some of them slightly low, but not absent. The tonsils are normal size or large. They present with recurrent infections, recurrent meningitis, pneumonia, ear infections, and commonly associated with autoimmune complications, and this is high yield. Rheumatoid arthritis, autoimmune hemolytic anemia, vitiligo. Risk of malignancy is high. They may have lymphoma or present with lymphoma. Treatment is simple. Low immunoglobulins to give them immunoglobulin. Low antibodies, give them antibodies, IV or subcutaneous. It is very important to be able to differentiate between these three conditions. Very easy to get confused. Severe combined immune deficiency, or SCID from the name combined. So humoral, which is B cells and T cells. So this is combined and appears shortly after birth or before 3 months of life. And if no bone marrow transplant, they usually die by 2 years of age. XLA appears after 6 months of life when the maternal antibodies disappear from the circulation. And the common variable appears during adolescence or after, very rare before 6 years of age. In SCID, you will not have any antibodies and also associated with lymphopenia because of T cells. And in XLA, absent antibodies. In common variable, the level of the antibodies are low and variable in levels. So remember, variable, low levels, but not absent. And in SCID, you do not have tonsils, you do not have thymus or very small thymus. In XLA, absent tonsils, and in common variable, the tonsils are normal size or large. Transient hypogammaglobulinemia of infancy, THI. It's a transient condition started at age 6 to 12 months of age when the maternal antibodies cleared from the circulation and resolve by 3 to 5 years of age. Clinical presentation asymptomatic or symptomatic. When it's symptomatic, they present or may present with frequent and recurrent otitis media, sinusitis, bronchial infections, life-threatening infections like severe sepsis or recurrent meningitis are rare. Transient in children more than 3 years of age, they will have less frequent infections even if the serum immunoglobulin not yet normalized. Common association with this condition is asthma and allergies. These infants, they have normal tonsils, adenoid, and lymph nodes. Why? Because the process of differentiation of B lymphocytes is normal. The diagnosis here near or near normal response to vaccination. So if you do titers to diphtheria, tetanus, or pneumococcal vaccine, you will see the antibodies normal or near normal. If you compare that to the common variable, the presentation, of course, is different here during adolescence, here during infancy. They have low immunoglobulins but no response to vaccination. In this condition, they have normal or near normal antibody level or response to vaccination. They have low immunoglobulins. Of course, you have to adjust for age with or without decrease in IgA and IgM. The T cell immunity is intact. The treatment is supportive antibiotics, IVIG in severe cases. Selective IgA deficiency. It is defined as undetectable serum immunoglobulin A less than 5 mg per deciliter. It is the most common primary immune deficiency in children. The clinical presentation, 90% of these cases are asymptomatic. However, 80% of these cases may develop symptoms later. Various GI tract infections like diarrhea caused by viruses, bacteria, or even protozoa like Giardia and Cryptosporidium, very common. Recurrent sinopulmonary infections, otitis media, recurrent pneumonia, especially with encapsulated bacteria like Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Diagnosis very low or absent IgA. These children are at increased risk of anaphylaxis if they are given IgA containing materials like blood, plasma, or IVIG. The treatment is antibiotics prevention to give vaccinations on time, and also boiling water to prevent infection with Cryptosporidium or Giardia. X-linked hyper-IgM syndrome. From the name affects the boys. Hyper-IgM means that the IgM can be normal or high in this syndrome. The idea of this disease that you have, as we learned before, that the CD4 T lymphocyte, the helper cells, stimulate the naive B cells to produce antibodies. So these antibodies, or the process of production of antibodies, is working normal. So the B cells will produce IgM with no problem. But the IgM need to be switched to IgG, IgA, and IgE. You require something called CD4 ligand to do the class switching of IgM to IgG, IgA, and IgE. Because of defect in this ligand, CD4 ligand, the process of switching of IgM to these three antibodies will be affected. So you will have low IgG, low IgA, and low IgE, and the IgM can be normal or high. Because of low IgG, you will have pyogenic infections, pneumonia, especially with pneumocystis jirovecii, and mucosal infections because of IgA deficiency, and recurrent diarrhea, especially Giardia, and also wars and molluscum contagium. This is less common. The pneumocystis jirovecii is the most common recurrent infection or pneumonia. So again, hyper-IgM syndrome is X-linked, affect the boys with hyperimmunoglobulin because of mutation in the gene that codes for CD4 ligand. CD4 ligand switch the IgM to the other antibodies. This appears in the primary infection, but in order to switch it to other antibodies, you need CD4 ligand. And because of the defect in this gene, you will have recurrent infections, especially pneumocystis carinii or pneumocystis jirovecii. So these patients, they present with recurrent pneumonia. This is the most frequent. And also they present with mouth ulcers, Giardia, because of lack of IgA. And less frequent, they have warts and molluscum contagiosum. Diagnosis of this disease, they have neutropenia, and this neutropenia can be chronic, cyclic, or occasional. And if you do immunoglobulin levels, you will see the IgM is normal or high, but the other antibodies, IgA, IgG, and IgE, they are low. And if you do flow cytometry, you will see deficient CD4 ligand on activated CD4 positive T lymphocyte. Management: immunoglobulin replacement therapy on regular basis, IV or subcutaneous. Giving Bactrim to protect against this furious bacteria. Neutropenia can be corrected with granulocyte colony stimulating factor. Bone marrow transplant with variable outcome. Let's take a break with this clinical case scenario. This is a 3-year-old girl with history of recurrent infections, coarse facial features, severe eczema. 2 weeks ago, she was hospitalized because of pneumonia. Chest X-ray showed alveolar consolidation and cavity formation. CT scan was ordered and showed thin-walled lung cavity. What is the most likely underlying condition? So the keyword here, you have recurrent infections, coarse facial features, severe eczema, and pneumatocele. So again, recurrent infections, coarse facial features, and thin-walled lung cavity or pneumatocele. These keywords are very important diagnostic points for hyper-IgE syndrome. Again, hyper-IgE syndrome, or well known as Job syndrome. From the name, they have a very high level of IgE. It is autosomal dominant or recessive, and also can be sporadic. The clinical presentation: recurrent skin abscesses, recurrent pneumonia with pneumatocele, especially staphylococcal infections, atopic dermatitis or severe eczema, and coarse facial features. Diagnosis of Job syndrome from the clinical pictures, and if you do immunoglobulin level, you will see the IgE level is severely elevated, 100 times greater than normal, so you cannot miss that. The treatment is prophylactic antimicrobial against staph and candida. Eczematous dermatitis require rigorous topical therapy, so treatment of eczema with hydration of the skin and topical steroids. X-linked lymphoproliferative syndrome. X-linked means affects males only, and whenever you see this disease, X lymphoproliferative or XLP, remember EBV virus infection. EBV, Epstein-Barr virus infection, commonly associated with this illness, and this can cause fulminant infectious mononucleosis. This can cause massive hepatic necrosis, hepatic encephalopathy, and death. Also can be associated with a systemic disease, hemophagocytic lymphohistiocytosis because of EBV, and this can present with fever, hepatosplenomegaly, skin rash, and pancytopenia. Also common association with this disease, high triglyceride level and elevated serum ferritin. Also whenever you see EBV, know the common association is lymphoma, hypogammaglobulinemia. And if you do peripheral smear for this disease, EBV virus can cause a reactive lymphocyte or atypical lymphocytosis. The lymphocyte will be larger in diameter with abundant cytoplasm. This can be seen also with cytomegalovirus and hepatitis. So the reactive lymphocytes is non-neoplastic, is just reactive to infectious cause, commonly EBV virus infection. And whenever you suspect EBV virus, you need to do the titer IgM and will be positive in this case. Genetic testing will confirm the diagnosis. Treatment is stem cell transplantation. So finally, remember XLP, EBV virus infection, massive hepatic necrosis. Wiskott-Aldrich syndrome is a very interesting disease, very easy to remember. It is X-linked recessive, affects males or boys only because of mutation in Wiskott-Aldrich syndrome protein gene. And the common presentation of this disease is bloody diarrhea, prolonged bleeding after circumcision, atopic dermatitis or severe eczema, recurrent infections with encapsulated bacteria, and death from recurrent infections by age 6 to 11 years of age. The key words for this disease: eczema, thrombocytopenia, and small platelets. Remember that ITP or idiopathic thrombocytopenic purpura will be associated with thrombocytopenia, but the platelets will be large. In this case, here in the Wiskott-Aldrich syndrome, remember the platelets are very small. So, and this is easy to see in the peripheral smear. So if you do just a CBC with peripheral smear, you will be able to diagnose this disease. And if you see the eczema with it and recurrent infections, and if you do flow cytometry and you see the T cells is affected, this will confirm the diagnosis of this disease. Very important to know the associated risk of Wiskott-Aldrich syndrome because of the T cells, the risk of lymphoma because of EBV infection and leukemia. The diagnosis of this disease, flow cytometry will show decreased T cell number and function, low IgM level. Prenatally can be diagnosed if you have a positive family history, and this can be done either by chorionic villus sampling or amniocentesis. The treatment is skin care for eczema. In cases of severe thrombocytopenia, you need to give IVIG with or without corticosteroids. If the child is bleeding, you need to do platelet transfusion, splenectomy, and stem cell or bone marrow transplants. Another high-yield disease is DiGeorge syndrome. DiGeorge syndrome because of failure of development of the third and fourth pharyngeal pouch, and because of microdeletion of chromosome 2211. And in this case, lack of or failure of development of third and fourth pharyngeal pouch, this will be associated with lack of development of thymus. The bone marrow will produce T cells, but the T cells will not find the thymus to be processed to be CD4 and CD8 to give you protection, so you will have T cell deficiency. And also parathyroid develop from the third and fourth pharyngeal pouch. You will have lack of parathyroid, so the newborn will present with hypocalcemia. Also this disease is commonly associated with heart problem like tetralogy Fallot, problem with great blood vessels like the aorta and pulmonary. And whenever any newborn or any infant or a child is having a problem with the great blood vessels, they have to be tested for DiGeorge syndrome even if they don't have any other symptoms. Also, this disease is commonly associated with abnormal facial features. Ataxia-telangiectasia is because of a mutation of Ataxia-telangiectasia mutated gene located at the long arm of chromosome 11, location 22-23. It is autosomal recessive. This is high yield and affects the T cells and B cells. And because the T cells are affected, the thymus gland will not work, so it will be small, so you will have thymic hypoplasia. This disease is very interesting. It starts with ataxia followed by telangiectasia and end with infection. So they start with ataxia at age of 2 and at age 3 to 7 they develop a telangiectasia in the eye and the skin. In the eye you will see dilated blood vessels on clear sclera. In conjunctivitis you will see the sclera is reddish or pinkish, but in this case you will see the sclera is clear, is white, and on the top you will see the dilated blood vessels, ocular telangiectasia. And then they will develop infections when they are older. These kids, they are not able to ambulate usually by age of 10. So this disease is high yield, you need to remember. Because the T cells are affected, also the B cells will be affected as well. You will have variable immunoglobulin deficiency, especially immunoglobulin A, recurrent sinopulmonary infections with encapsulated bacteria, progressive neurologic disease. Whenever the T cells are affected, there is a risk of malignancy. You will have here lymphoreticular malignancy, non-Hodgkin lymphoma, and leukemia. What is very interesting in this disease, you will see elevated alpha-fetoprotein, and also you will see decrease in IgA and IgE. If you do MRI, you will see cerebral atrophy and ventricular enlargement. Very important to know about this disease, they are very sensitive to radiation. So when you order a chest x-ray or if you have alternative like ultrasound or MRI, so it's better to do, because these patients, they are very sensitive to x-ray, even if they are carriers, even if they do not have the disease but they are just carrier, they are very sensitive to radiation. The treatment is IVIG, antibiotics. The bone marrow transplant is not a viable option of this disease because of cellular radiosensitivity. Whenever ataxia-telangiectasia is mentioned, we need to differentiate that from Friedreich's ataxia. Both of them are autosomal recessive. Here chromosome 11, chromosome 9 in Friedreich's ataxia. Both of them, they develop ataxia. The age of presentation early in this disease, 1 to 2 years of age. Here later in life, 8 to 15 years of age. They require wheelchair by age of 10. In case of Friedreich's ataxia, loss of ambulation 15 years after the onset of the disease, so can occur 20 to 30 years of age. In cases of ataxia-telangiectasia, they have intact sensation and negative Romberg sign. Friedreich's ataxia, they have spinal or sensory ataxia and positive Romberg sign. In cases of ataxia-telangiectasia, from the name they have telangiectasia, they have immune deficiency. None of that in cases of Friedreich's ataxia. In this section, we'll discuss diseases and disorders associated with phagocytic activities. Leukocyte adhesion defect. The idea of this disease is that the leukocyte cannot migrate to the site of the infection, so you will have infection without pus. Why? Because of lack of integrin. The integrin is a CD18 subunit, lymphocyte. And this integrin will attach the leukocyte, or will adhere the leukocyte to the cellular adhesion molecules, and will pass the leukocytes to the site of infection. If you do not have the integrin, this will not happen, and you will have infection without pus. So at the site of the infection, like cellulitis or abscess, you will see serosanguinous fluids without dead neutrophil. Delayed umbilical cord separation is a key word for leukocyte adhesion defect. Normally, the umbilical cord separates as early as 3 days, as late as 45 days. The mean is 10 days. If you see the umbilical cord persist more than 2 months, this is the time you start to think about this disease, leukocyte adhesion defect. What to do next? Do a CBC. If the white count is very elevated, like 45, 50, or 60,000, this makes this disease very likely. Why the white count will be elevated? Because half of the white blood cells normally hanging to the wall of the blood vessels. And without adhesion, without integrin, this white blood cells will be released in the circulation and will give you a very high white count without even infection. And these patients, when they have infection, they very commonly to be associated with staph infections, and they develop recurrent abscesses. And at the site of the abscess or the wound, you will not see a pus or dead neutrophils because of lack of adhesion. And these patients also may have recurrent fungal infections, poor wound healing, and they may develop ulcer because of chronic skin infections. Diagnosis, to confirm the diagnosis, flow cytometry, and you will see the lack of expression of CD11 and CD18 on the neutrophil. Treatment is Bactrim to cover for staph, to protect from staph infection, Bactrim prophylaxis, bone marrow transplant, and gene therapy. Chediak-Higashi is a disease associated with a problem with protein trafficking and impaired phagolysosomal function. This can affect any tissue in the body. So the idea here, if you have a cell or neutrophil, for example, and you have the phagosome or the phagosome and the lysosome, and you need both to combine together, and you have the phagolysosomal function, you need a protein trafficking protein between both in order to function. So lack of this protein will impair function of many cells. For example, this will affect the phagocytosis of bacteria in the white blood cells, will impair the division of the cells because of lack of protein to divide the material, the cell material between the cells, so you will have neutropenia and recurrent infections. And also same idea here, this disease also have giant granules in the leukocyte. Why? Normally you have in the neutrophil, you have Golgi apparatus distributes the granules all over the cell evenly, and if you have problem with the protein trafficking, the process of distribution will be affected, so the granules will keep accumulating and accumulating, then will make a big giant granules in the leukocyte, and will be easy to see that in the peripheral smear, and this is high yield. Another problem also is impaired platelet function because also of lack of distribution of the granules in the platelets. This will affect the platelet function and will be associated with bleeding. Also the same idea, the lack of trafficking protein, this will impair the transfer of melanin from the melanocyte to the keratinocytes to give the color of the skin, and this will present with albinism. Another problem is progressive peripheral neuropathy. Same idea also, you have any cell neuron, usually it has the cell body, the neuron it has the cell body, the axons and the peripheral nerves, and the cell body is the brain of the neuron, and lack of protein trafficking system or lack of this microtubules or this railroad to transfer the information from the cell body of the neuron will be associated with progressive peripheral neuropathy. So remember, Chediak-Higashi associated with neutropenia, recurrent infections, giant granules in the leukocyte, bleeding, and albinism, finally progressive peripheral neuropathy. Let's verbalize what we have discussed in the previous slide. Chediak-Higashi syndrome is autosomal recessive, associated with partial oculocutaneous albinism, photophobia, nystagmus, progressive peripheral neuropathy, mild bleeding because of impaired platelet function, recurrent infections. Very important to know the risk of malignancy associated with Chediak-Higashi, leukemia, lymphoma, hemophagocytic lymphohistiocytosis. Diagnosis in the peripheral smear, you will see giant granules, and these granules are peroxidase positive. The treatment of this disease is bone marrow transplant plus or minus high dose of ascorbic acid plus or minus interferon. This slide to summarize two important diseases we like to discuss in this section: chronic granulomatous disease and myeloperoxidase deficiency. If we understand the idea of the phagocytosis and killing the bacteria, will make it easy for us to remember everything about these two diseases. So you have here, this is the white blood cells. It has granules and it has the polysegmented nucleus. The granules are rich in an enzyme well known as myeloperoxidase enzyme. And when the bacteria enter the body somehow, the neutrophil will extend two arms and will phagocytose these bacteria. But these bacteria, to be killed, need some assistance, need some oxygen radicals or acids to burn or bleach this bacteria. So how this happened? By myeloperoxidase, and enzyme is well known as NADPH oxidase. So each cell, like neutrophil, monocytes, they have respiratory burst where they are able to convert the oxygen to oxygen radicals. So the oxygen to oxygen radical by the action of this enzyme will known as NADPH oxidase. So NADPH oxidase will be able to convert the oxygen to oxygen radicals where they have some killing activities against the bacteria, H2O2 and the chloride ions. And the myeloperoxidase in the granules here will be able to convert these two radicals to something much more potent acid, 50 times more killing power than the hydrogen peroxide and the chloride ions, is well known as hypochlorous acids. Hypochlorous acids will bleach the bacteria and kill the bacteria. So what happens here if you do not have NADPH oxidase? You will not be able to convert the oxygen to oxygen radicals. So you will not have hydrogen peroxide, you will not have chloride ions, and of course no hypochlorous acids. So these children, they will be very sick children. They will develop abscesses and infections in multiple sites in the body. So the classic presentation is a boy because it's X-linked with liver abscess. Liver abscess is just a key word, but they can have abscess anywhere in the body. So chronic granulomatous. Granulomatous is a chronic disease and associated with granulomas. So chronic granulomatous disease is deficiency of NADPH oxidase. So how to test for this disease? From the name. So this disease is depending on the respiratory burst. Because of deficiency of NADPH oxidase, so you will be able to test the neutrophil oxidative burst test, flow cytometry. So the flow cytometry will be able to measure the level of hydrogen peroxide and the chloride ions and will give you the result for this test. If it's deficient, is not there, this is chronic granulomatous disease. The myeloperoxidase deficiency, they will not be able, this patient will not be able to convert the hydrogen peroxide and the chloride ions to the potent acid hypochlorous acids. So they will be asymptomatic because the killing activity will be impaired because they still have hydrogen peroxide and the chloride ions. But if they develop symptoms, they may develop candidiasis. So the bacteria after the phagocytosis will be killed by the endogenous hydrogen peroxide and the chloride ions appears from the bacteria, and the white blood cells or neutrophil will use it against the bacteria and will bleach and kill the bacteria. But this cannot be happen with candidiasis. So a few cases they will have candidiasis or fungal infection, but generally myeloperoxidase deficiency is asymptomatic. So again, very easy. Chronic granulomatous disease is deficiency of NADPH oxidase. They will not be able to convert the oxygen to oxygen radicals. So they will not be able to kill the bacteria, so they develop severe diseases like liver abscesses, skin abscesses, failure to thrive, chronic diarrhea. They are very sick. Children with myeloperoxidase deficiency, they are not just not able to convert the superoxides to potent acids like hypochlorous acid, and these patients are asymptomatic, and if they have symptoms will be candidiasis or fungal infection. Again, myeloperoxidase deficiency is autosomal recessive because of lack of production of myeloperoxidase enzyme, is easy from the name. Usually asymptomatic. If they have symptom will be candidiasis. The treatment is antifungal if they have fungal infection. If there is no infection, no treatment. Chronic granulomatous disease is X-linked recessive, so affected the boys. So you expect to see the presentation only in boys. Because of deficiency of NADPH oxidase enzyme, and this will not be able to generate the hydrogen peroxide or hydroxyl radicals or superoxides. The polymorphonuclear leukocytes is neutrophil unable to kill the ingested bacteria, so they do the phagocytosis, but they are not able to kill it because of lack of the superoxides. Clinical presentation of chronic granulomatous disease. This disease affects the boys only, very important. So a boy with pyogenic infections, for example, multiple skin abscesses or recurrent skin abscesses, lungs, like for example pneumonia or lung abscess, liver abscess, GI tract infection like chronic diarrhea, osteomyelitis at multiple sites, recurrent osteomyelitis at different sites, different locations in the body. This is unusual. This is very abnormal and should raise the flag for chronic granulomatous disease or other immunologic disorder. Formation of granuloma, from the name, so easy to remember. Failure to thrive. The diagnosis of this test is high yield and frequently tested in the pediatric board examination. The most reliable and useful test is flow cytometric assessment of respiratory burst. The name of the test is neutrophil oxidative burst test. Neutrophil oxidative burst test, to test the radicals using the flow cytometry using rhodamine dye. So this test is very important to remember. And now after the diagram we draw, is very important now to understand and remember why respiratory burst. The treatment is BMT or bone marrow transplant, supportive care, prophylactic Bactrim, surgical drainage of abscesses. We'll start a new section, disorders of complement system. Complement is a protein mainly produced by the liver. It helps the phagocytic cells and antibodies to clear pathogens. The complement is usually not active until become activated through the classical pathway or alternative pathway. The classical pathway when the complement combine to the antibodies and will be activated in this site from C1. And alternative pathway when the microbial products of organism directly activate the complement and will start to activate from C3. And from either this side and this side, you will end up having C3A, and this through a cascade of activation will end up to C9, and at the end you will make something called membrane attack complex, and this will make a hole in the organism and destroy the organisms. And very important to know that if you have a defect in the initial part of the complement from C1 to C4, this is commonly associated with autoimmune disease. For example, in cases of lupus, you will see C3 is low and C4 is low because of consumption of immune complexes attacking the joints, the skin. So you will have C3 is low and C4 is low. In cases of post-streptococcal glomerulonephritis, you will see C3 is low and C4 is normal in most of the cases. Very important to know about C1. C1, it has an enzyme is well known as C1 inhibitor. Deficiency of this or defect in this enzyme, you will have a problem with the C1. So the C1 will fail to block the action of bradykinin, and they will end up with having angioedema. And this is well known as hereditary angioedema because of deficiency of C1 inhibitor. The terminal part of the complex is associated with infections from C5 to C8, commonly associated with Neisseria infections and recurrent meningitis. From C5 to C9, commonly associated with infection and sepsis. When C3A convert to C3B, C3B is very important for opsonization and coding organism, and combine with the immunoglobulins like IgM or IgG and the phagocytes and destroy the organism. C5A, very important for inflammation, attraction of neutrophils to the site of the infection. Again, the initial defect of a complement system associated with autoimmune disease, and the terminal defect of the complement system associated with increased risk of infections. Clinical presentation: if you have genetic deficiency from C1 to C4, this is associated with autoimmune diseases. Genetic deficiency from C5 to C9, increased susceptibility to infections. From C5 to C8, this increased susceptibility to recurrent Neisseria infections or recurrent meningitis. Screening for complement deficiency or complement defect is CH50. This is the best test you can order and is a high yield. For autoimmune diseases, if you suspect autoimmune disease, C3 and C4 are very helpful. Like in cases of lupus, both of them they will be low. In cases of post-streptococcal glomerulonephritis, C3 will be low and C4 will be normal in most of the cases. In cases of nephrotic syndrome, you will see C3 and C4 are normal. This is very helpful in diagnosis of many autoimmune conditions. Treatment of Neisseria or meningitis infection with Neisseria, third generation cephalosporin covers for most of the strains of Neisseria like ceftriaxone or cefotaxime. Initial immunologic testing of a child with recurrent infections. What to order first when you suspect a primary immune deficiency, CBC? You cannot really count how many diseases you are able to diagnose by just looking and learning how to read CBC. How many diseases you are able to exclude by just learning how to understand complete blood count. Normal absolute lymphocyte count rules against T cell defect. Normal absolute neutrophil count rules against congenital or acquired neutropenia. Normal platelet count and normal size of platelet excludes the Wiskott-Aldrich syndrome. Absence of Howell-Jolly bodies rules against asplenia. Normal ESR makes chronic bacterial and fungal infections are unlikely. Initial testing for B cell defects directly measure the immunoglobulin levels by measuring IgA, IgM, IgG, and IgE. and measuring the antibody function by measuring the antibody titers to vaccine if the child was vaccinated. So you measure the antibodies to tetanus, diphtheria, Haemophilus influenza, and pneumococcus. If they are normal, it's very unlikely that this child is having B cell defects. If they are low, you need to confirm by giving a vaccine, for example, pneumococcal vaccine, and you retest the child again in 3 to 4 or 5 weeks. You measure the antibody level against the pneumococcal vaccine. If it's low, this will be suggestive of B cell defect. Initial screening for T cell defects: if you have normal CBC with normal absolute lymphocytic count, this makes the T cell defect is unlikely. Candida albicans intradermal skin test is another method to test for cellular immunity by giving candine intradermal, and you make a blip is 0.1 ml, similar like you are doing exactly tuberculin test. For 8 hours, if you see the induration more than or equal 5 millimeter, this is positive, means that the T cell defect is unlikely. You can use also diphtheria or tetanus toxoids. Let's summarize some of the high yield points. If you have a case with recurrent infections and the age is less than 6 months, present with failure to thrive, chronic diarrhea, absent tonsils and thymus, this is a case of severe combined immune deficiency. If the age is more than 6 months after the maternal antibodies cleared from the circulation of the infant, absent tonsils, absent lymph node, and is a boy, it is suggestive of X-linked hypogammaglobulinemia. If this is an adolescent and with low immunoglobulins and low immunoglobulin function, also poor response to vaccination, so they do not develop antibodies to vaccine, and normal tonsils, this is common variable immune deficiency. Recurrent Staph aureus infections, pneumatocele, coarse facial features, the eczema, this is a key words for hyper IgE syndrome. Recurrent lung infection with pneumocystis carinii or pneumocystis jirovecii, mouth ulcers, severe neutropenia, this is are keywords for hyper IgM syndrome. Recurrent GI infections, especially giardia, recurrent sinusitis, low IgA, this is IgA deficiency. A boy with recurrent abscesses in unusual places like liver, brain, or recurrent osteomyelitis in different places, this is suggestive of chronic granulomatous disease. Delayed separation of umbilical cord more than 2 months, leukocytosis or very high white count like 50 or 60,000, no pus at the site of the infection, this is suggestive of leukocyte adhesion defect. Thank you for listening.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This video is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.